this is just the beginning.
Hello, and welcome to Axios virtual event, Healthcare 2021. I'm Sam Baker, the healthcare editor here at Axios, coming to you from my home in Washington, D.C. I'd like to thank United Health Group for making these conversations possible, and I'd like to welcome our audiences on Facebook, YouTube, Twitter, LinkedIn, and Axios.com. You can also follow along on Twitter using the hashtag Axios Events or by following @Axios. Over the next 30 minutes, we will unpack the best ways to expand health insurance access and health insurance coverage in the United States and exactly what that path forward looks like, both following the presidential election and in the midst of a pandemic that is getting worse every day. Our first guest today is Senator Tina Smith of Minnesota. Senator, thank you so much for joining us.
Well, thank you, Sam. It's really terrific to be with everyone today.
I'd like to start off just to sort of frame this conversation. Obviously, healthcare access and health insurance coverage has been a very hot topic for a very long time. But I think that the pandemic has sort of highlighted and illustrated some of the gaps that we're dealing with in this system. We've seen millions of people lose their health insurance because they lost their jobs in the economic downturn. That obviously affects not just those people, but also their family members then lose their health insurance. And so I'm just curious, how has that shaped or changed the way that you view this problem, specifically of healthcare coverage? Do you see that any differently now?
Well, I mean, I think you raise exactly the right point. Here we are in the midst of a global pandemic, and in fact, it's a pandemic that is surging in my home state of Minnesota and in the upper Midwest and all across the country. We had yesterday 56 deaths from COVID-19, the highest count that we have ever had. And as we see infections go up, we see hospitalizations go up, and we see deaths going up everywhere. And this reveals some of the systemic inequities that we have in our healthcare system, some of the weaknesses in our healthcare system that we have got to address. This is a long story for Minnesotans and for people all over this country, the struggle to figure out how to get healthcare that you can afford, no matter who you are or where you live, and have access to that healthcare, no matter who you are or where you live. So COVID, of course, we know is not the great equalizer. It is revealing these fundamental inequities, especially as we see in my home state and all over this country, the disparities that are revealed by frontline workers, Black and Brown and Indigenous people, older people, rural people who really struggle to get access to healthcare. So this should be a moment for us to address this. First, we've got to be focused on getting this pandemic under control. And I've got lots of ideas for how to do that, but then be able to look towards how we're building towards a better future for healthcare and for Americans.
So one, this is probably the wrong way to describe it, but somewhat positive side effect of this terrible experience has been an increase in telemedicine, which I know is something that's been very important to you. What needs to happen, whether it's in Congress or just in the new administration, to make that stick?
Yeah, well, the point that this is a really important point, which is in the midst of crisis, we often make big leaps forward in innovation. And we need to make sure that that doesn't waste, that it doesn't go away as we work our way through this crisis. And that is very much the case in telehealth. With the inability of people, people not being able to go to see their doctor, we see this massive expansion in telehealth, not only for physical health, but also for things like mental health, where we have a dramatic shortage of providers and shortage of access to care all over this country. So one thing that I'm very excited about is how we can make sure that these innovations in telehealth, expanding it, doesn't go away when the pandemic is over. This is something that providers and patients have really appreciated and have described to me as a lifeline. I care a lot about the access to mental health, and certainly in the midst of this pandemic, we know that the need for mental health has exploded. Whether you are a frontline healthcare worker or whether you are a senior who is living with a lot of social isolation, the upsurge in depression, anxiety, and also suicidal ideation are going up dramatically. These are things that telehealth can also help, not as a complete substitution for in-person care, but as a way of making care more accessible.
And I want to come back to your point on mental health, but just real quickly on telehealth, do you think the challenge here is it reimbursement? I mean, we've seen Medicare and Medicaid, I think, bump things up to try to make this change happen. Is it patient attitude, sort of internalizing, this is the way to see my doctor? Is it something that needs to happen among providers? What are sort of the moving pieces there?
Well, a crucial piece is reimbursement, and the CMS provided waivers for reimbursement for telehealth, video telehealth, and even just phone telehealth in order to make sure that access to care stood. And what we need to make sure is that those higher reimbursement rates on a par with a personal visit don't go away. That'll make a huge difference for providers who need to be able to have a reimbursement that is sustainable. It's also, I think, partly a shift in attitude towards patients. And this is going to vary a lot depending on who the patients are. But here's just one example of this, a story that I heard about a person in rural Minnesota who needed mental health care. This person was very unwilling to drive to the doctor's office because it felt so exposed, and there still is so much stigma around mental health. However, that ability to get care in the privacy of their own home made it actually more accessible because they were protected from some of that feeling of being exposed that is a barrier to people getting mental health care. So I think it can work both for patients as well as for providers, as long as we have reimbursements that actually work.
And so to pick up on your point about mental health, we have seen these reports that you alluded to that mental health and behavioral health issues have really increased during the pandemic, whether that's depression, substance use, anxiety, the whole list that you just articulated. Clearly, or at least the strong implication is that a lot of that has come from some of the lockdown measures and the social isolation that is necessary to spare people from a deadly virus. What I'm wondering is there a way to square that? Is there a way, telehealth is maybe part of it, but what else is necessary to sort of ensure that people can stay healthy in both ways?
Yeah. Well, we have to be aware of all of the risks and all of the costs of this pandemic, even the costs that are not I guess you could describe them as secondary. And I think that mental health is definitely in that category. Being somebody who's always looking on the bright side, I believe that what we are also seeing is a greater recognition and a greater willingness to talk about mental health as something that is part of our whole health and not something that is sort of separate and apart. We need to take this as a moment to continue to push through the discrimination and stigma that still exists around mental health. It gets to something I think is very important about ways that the steps that we need to take to suppress the virus, because we have clearly moved past the point where the only tool that we have in our toolbox is to ask everybody to stay home and not go out. That is just not feasible. Think particularly of the impact of people that are frontline healthcare workers or other frontline workers. And this gets to why it is so important that we have a robust national testing and contact tracing and humane isolation strategy so that the people can be more likely to go about their business in ways that are safe. And this has got to be testing that isn't just diagnostic testing, but also surveillance testing, which will be a path towards getting our economy functioning while we are waiting for a vaccine to be broadly available. I have a bipartisan bill to accomplish this with Senator Bill Cassidy from Louisiana that is built around the idea of establishing state purchasing compacts to dramatically ramp up access to testing, rapid testing, not only for diagnostics, but for surveillance.
Well, speaking of bipartisanship, just one final question here, and we'll let you go. Control of the Senate obviously is still up for grabs. We're going to be in a deeply divided Washington no matter what. Healthcare traditionally is not really a wellspring of bipartisan good feelings. So what is it realistic for people to expect here in the next year?
Well, I come from the school of thought which says that bipartisan legislation, bipartisan laws are always the most sustainable laws. It causes us to, we need to find ways of coming together around these issues. And let's remember that earlier this year, we successfully came together with some really significant responses to this global pandemic with the CARES Act and with other broadly bipartisan legislation that we passed. So the onus is going to be on all of us, Democrats and Republicans, and with President Biden to address the needs that Americans have and put aside our partisanship. And I mean, I will tell you, in the conversations I've had with Minnesotans, they don't see healthcare as a political issue. They see it as an economic issue. They see it as a hugely personal issue about the safety and the health and the well-being of their families, their kids, their parents. And I think that has to guide us as we look for bipartisan solutions like Bill Cassidy and I have around testing and contact tracing. And for example, supporting rural health, which is, again, another place where I think Republicans and Democrats can come together.
All right. Well, that seems like a good place to leave it. Senator, thank you so much for taking the time and joining us today. Really appreciate it.
Thank you. Really appreciate it.
And up next, we have a View from the Top segment with Axios co-founder and CEO Jim Vandehei and the CEO of Optum Health Services, United Health Group, Heather Cianfrocco.
Thank you very much, Sam. It's now my pleasure to bring you a conversation with Heather Cianfrocco, who is the CEO of Optum Health, which is part of United Health Group. Heather, thank you for joining us.
Great to be here. Thank you, Jim.
Can you give people who are watching the smart brevity version of what Optum Health is and what United Health Group is?
Sure. So United Health Group serves people across the country and across the globe, really working to make sure that people live healthier lives and to make the health system work better for everybody. We're basically in many aspects of healthcare. Our health insurance side of the business, what we call the benefit side of the business, that's United Health Care, which many people know about, and then our Optum services, which encompasses our data and technology segments, our RX and pharmacy specialty businesses, together with our Optum Health Services, where we bring delivery services through our Optum Care practices, over 50,000 physicians, and enabling providers and practitioners across the country, as well as our health businesses, which are population health, military and veteran support solutions, house calls programs, and other complex care management programs. And we offer those through United Healthcare and through other clients and customers. And then we have a global part of our business that really services countries around the globe. So it's a large enterprise with a large focus and dedication to healthcare.
So you have some of the best data, one of the best sort of lenses into what's happening in the healthcare system. Talk about the effect of the healthcare system amid the pandemic, right? It's sort of the defining topic of our generation. What has it done to the healthcare system?
Yeah, it's a great question, Jim. So maybe just even, thinking a little bit, I really appreciate that you asked about United Health Group and United Health Group's sort of purpose and function, and maybe just a little bit of background. Know that one of the things United Health Group is really focused on, and has been even more amplified by the pandemic, is really an approach to a next generation health system. And that means a couple of things. It means universal coverage. It means affordability for everyone. It means improved healthcare outcomes, and it means a better experience for consumers and for practitioners. And we've been advocating for that for over 20 years, but also making sure we're part of the solution, working very hard to advance those components of a next generation health system. And I guess what I would say is what we learned from the pandemic was that the things that already didn't work in the system, were even more broken. But then we learned that as we come together with private-public partnerships, we can advance very quickly. So maybe a couple of examples. We noticed that, we saw surprise billing. Surprise billing was an issue before the pandemic, but it became an additional anxiety provoker for our consumers when during the pandemic, people may have experienced a surprise bill. We know there's a solution to that, a public-private partnership working together, creating a median in-network rate will resolve a lot of surprise billing for people, anxiety, and will reduce costs to consumers and employers by about $40 billion. Those are examples of things that, continue to be exacerbated by the pandemic. But then on the other side, think about telehealth. Telehealth we needed telehealth before the pandemic. We saw an even greater need for telehealth. How did it show up? It showed up in a way that we were able, through federal regulatory and state regulatory support, again, public-private partnership, to actually bridge the gap in telehealth. We were able to provide more virtually as a result of, removing originating site requirements, state boundaries. And I can say even in our own business, take our Optum Care business, we have about 50,000 physicians. We've provided over 1 million telehealth visits as a result of being able to just expand telehealth services. So I think we've seen things that we needed to address as a result of the pandemic. We've been United Health Group working with partners, working with policymakers to really advance and move that faster. Workforce, last example maybe I would give is workforce. We can see a workforce shortage. So advancing a 21st century workforce that's more virtual, that addresses population health, and that can really go that extra step to address the health inequities we experienced through COVID as well.
Once the coronavirus is gone and things are back to normal, how much of my medical care, especially routine physicals, et cetera, should just be done by telemedicine and saving people trips to the doctor? Is that a tiny percentage? Is that half? Like how much?
It's a great question. I think, again, another thing I might point out that we're learning, through this pandemic is that we're learning what can be done virtually and then what really is still required to be done in person. And as we continue to adapt through better solutions, we found during the pandemic, let's take behavioral health, for example. Almost half of our services today, as a result of the pandemic, about half of the claims have been virtual or telehealth in nature. Obviously, that was a result of shutdowns across the country, but in many cases, what we found is we're able to provide even more access to people that either as a result of stigma, barriers, or just lack of access to appropriate behavioral health and specialized behavioral health services really couldn't access it. So I guess I would say we're going to continue to learn how much can be virtual versus inpatient as technology and data continue to evolve, as we continue to partner across the spectrum of public and private partnerships. We'll be able to do even more. The biggest opportunity I think that we noticed through this pandemic is the opportunity for people to continue to get their preventive services. Healthcare screenings are so important, and the ability to do that, in many cases, some of that will still continue to have to be in person, but we are committed to being part of the solution to make that even easier to access and bring it closer to home for people.
Well, the final question, maybe the most important question for people who don't have health insurance, how do you, like if I have health insurance, so if I get sick or I need to get tested, I'm fine. But for those people that don't have coverage yet, how do you think about that? What is the easiest way to get to a place where we do have 100% of the population covered in a way that does not slow down innovation inside the healthcare system?
I think that's a great question. And I think, it's on top of mind for everybody as we look to opportunities to expand coverage. But I think one of the things that's really important to start with is that although the goal is 100%, let's not forget that 90% do have coverage today. And the 90% that have coverage have really stable coverage that gives options, and it's based on success. It's really the result of proven public-private partnerships. Again, for example, the Medicaid program, the Medicare and Medicare Advantage program, an employer-sponsored program. So working from what we already know works. Start with Medicaid. Medicaid already covering over 70 million individuals. United Health Group through United Healthcare is one of the largest participants in that program across the country. But think about just expanding it in the 12 states that can continue to expand Medicaid, and ensuring that individuals that are eligible are presumptively enrolled in it. Always have a choice to get to opt out, but if they're eligible, they can join Medicaid. That would expand, coverage. Another example, Medicare Advantage. We've found that individuals, consumers save dollars on Medicare Advantage. So continuing to fund and support a stable Medicare Advantage program, and then taking exchanges, modernizing them, an exchange program, today we're in exchanges, and United Health Group is committed to being part of the solution and expanding them, but modernizing them, again, giving the opportunity to have individuals that would be eligible for subsidy, that they can be presumptively enrolled. Always an option to opt out, but to be able to be presumptively enrolled. That alone adds 18 million individuals to coverage right there. And then allowing states to expand and find that sometimes flexible options like short duration plans are necessary for individuals in a certain situation. So I think that's how we expand coverage, and then making sure that it's more affordable for people. So being thoughtful about the exchange programs and making sure that exchange coverage allows younger, healthy individuals to pay rates that are commensurate with their actual health experience and their healthcare status, and ensuring. And if we work from that base, I think that's an opportunity to continue to expand what's already a strong coverage platform and really get every individual covered.
Heather, thank you for a fascinating conversation. Thank you to Optum Health and the United Health Group for making this broader conversation about healthcare possible. And back to you, Sam.
Thanks, Jim. Our final guest today is Avik Roy. Avik is the president of the Foundation for Research on Equal Opportunity and a senior advisor at the Bipartisan Policy Center, and very much a fixture of the health policy debate here in Washington. Avik, thank you so much for joining us.
Hey, Sam, how are you?
Great. So just to kind of dive right in here, when we're talking about coverage and access, a point I've heard you make many times is that universal coverage does not necessarily have to mean government coverage. And when you look at the U.S., I feel like these distinctions can get sort of blurred for a lot of people, right? You have a lot of people, millions of people, get coverage from their employer, which they perceive as private, but they don't realize it's heavily subsidized by the government. Millions of people get insurance from Medicare, which they perceive as public, but don't realize a lot of it is actually private. And so, I'm wondering if you can just sort of, from a big picture level, walk through where, in your view, the private sector and the public sector sort of belong in the pursuit of universal coverage.
Yeah, it's a great point, a really important point to make, Sam, especially as we think about other countries as models for how to reform the U.S. healthcare system. A lot of people on both sides of the debate don't appreciate that universal coverage is not the same thing as single-payer government-run healthcare, in the sense that a lot of countries in Europe, or at least a number of them, have achieved universal coverage with private insurance companies or private insurers. And that's an important distinction. And as you said, that doesn't mean there's an absence of government involvement. In all of those countries in Europe, say, where they have a universal private insurance system, there's an effort to provide financial assistance in the form of subsidies and other things to low-income folks who otherwise wouldn't be able to afford coverage. There are regulations and other elements of the system, rules of the road, you might say, that bracket how the insurance coverage is defined. But broadly speaking, the way I look at it, and what I've tried to persuade free marketeers of, is that if you want a market-oriented system in healthcare, what does that mean? Ultimately, what that really means is you should have a broad range of choices as to the kinds of insurance you buy and from whom you buy it. And the flaw of a single-payer system is it's one system, it's one insurer, and you really have no choice if that insurer or that benefit or that system isn't working for you. You have nowhere else to go. Whereas in a system like Medicare Advantage, which you kind of alluded to earlier, Sam, yes, it's a government-sponsored system. There are government subsidies for people who can't afford their coverage, but you have dozens of choices to the kind of plan you buy. And that's why the plan that the health reform approach that we've talked about at FreeOp is called Medicare Advantage for All, because it highlights the point that when Bernie Sanders says Medicare for all, he's really talking about abolishing the health insurance that 40% of seniors use, which is private insurance.
Where do you think the Republican Party is right now on healthcare? That it's an issue that worked really well for conservatives toward the beginning of the Affordable Care Act era, when that was sort of the organizing principle. It seems that pendulum seems to have swung at least somewhat back in Democrats' direction. Why do you think that's happened? And is there anything in the near term you think that can reverse that?
Well, the bottom line to your question is, if the question is where are Republicans, there's no right answer to that question. There's no wrong answer to that question, because Republicans are all over the place. There's no consensus among Republicans as to what they think about healthcare. There are some that are leaning into the kinds of ideas that I've talked about. There's actually a bill that's been introduced by Senator Mike Braun of Indiana and Bruce Westerman, a congressman from Arkansas, called the Fair Care Act, that's based on a lot of the work that we've done that tries to achieve universal coverage through private insurance. So there are people on that, you might say, end of the spectrum, and there are those who say, let's repeal Obamacare and go back to the status quo ante, the old pre-Obamacare system, which is not sustainable. And then there's sort of people in the middle who, I think are certainly don't like being hammered on their lack of a plan or solution for the uninsured or for the affordability of health insurance. They're looking for answers, and they haven't figured out what they believe in yet. And that's, again, part of what think tanks are for, and that's part of why we built the Foundation for Research on Equal Opportunity, to try to solve those problems.
Fair enough. This next question is actually one from our audience, a question from a reader who asks, how can we reframe the discussions to address actual total costs, not prices or negotiated discounts? And so I guess to try to put sort of a finer point on that, one of the few things that people from both parties and really everybody outside the industry sort of agrees on is that some kind of price transparency in healthcare would probably be great for patients. But at the same time, as you know, trying to actually achieve that and find some actual number that you can give people that will be useful to them individually is very difficult. Is price transparency in healthcare possible? And is it worth doing, in your view?
Well, before we even talk about price transparency, let's make very clear that the price of healthcare in America is extremely high, it's unsustainable, it's unaffordable, and it's not the kind of system that you would want in terms of the prices if you had a true free market or market-oriented system, or if you had a single-payer system. Whatever side of the ideological or philosophical spectrum you're on, the prices we have are the worst of both worlds. We have a system in which we subsidize healthcare for almost everyone, but we have no accountability built into the system for the prices that patients are charged by often monopoly providers of those services. So that's a huge problem, and reformers on both sides have different ideas on how to address it. Price transparency is part of the solution, but it's not the whole solution. Let me get into why. First of all, it's worth noting, Sam, and you've talked about this some in your work, and some of your colleagues have as well. The Trump administration has actually done quite a bit on price transparency. The rules that are going into effect starting in January of 2022 that require all hospitals and insurers to disclose the rates they've negotiated with each other for various healthcare services, that's a revolution. And I guarantee you that there are people in Silicon Valley, in fact, I know for a fact, there are people in Silicon Valley today and people in the existing healthcare industry that recognize how disruptive that is, and how having that wealth of data is going to transform the way healthcare is bought and sold among a lot of different people in America. So that's really important reform that's still winding its way through the courts. But if it survives court challenges from the hospitals and others, it's going to be really important. Now, there's something that's really important to understand about price transparency that a lot of people don't understand. They say, well, if hospitals just post the price of a knee surgery or heart surgery on their window, then we'll all have better ability to shop. That's not true for a couple of reasons. One, 80%, if you take a typical employer-based plan, 80% of your healthcare dollars aren't paid for by you, the patient, directly. They're paid for by your employer or by the insurance company that your employer contracts on your behalf. So if your deductible is $1,000 or $2,000 and the knee replacement's $15,000 in one place and $10,000 in another, you don't care, because once you hit your deductible, the difference to you is not that great. So where you really need to have transparency as a consumer is in the price of the health insurance that you buy. And we don't have that, because if you get insurance from your employer, it's taken out of your paycheck pre-tax. You don't actually have any idea how much money is taken out of your wages to pay for that insurance. And if you get it from the government, even more so through Medicare or Medicaid or what have you. It's only actually, ironically, the people in the ACA, the Affordable Care Act exchanges, that have some real sense of how much they're paying for their insurance. So a big part of our approach to health reform is to increase the number of people who are shopping for their own coverage and get the reward for finding that value. Because if they can reward the insurers that are doing a good job of negotiating lower prices on their behalf, then those insurers will have stiffer spines to negotiate stronger or more carefully with hospitals and doctors and pharmaceutical companies. They don't have that incentive today.
mean, I don't need to tell you this, but that is you get a lot of incoming from a lot of different sides, trying to get more people shopping on their own, both ideological, but also resistance from employers. You're
some resistance from some employers, because yes, the Chamber of Commerce and the Fortune 500 companies, they love the status quo because they think it's a barrier. Like if you're an engineer at Apple and you know that Apple's going to pay for this very expensive employer-based plan, and you have a thought of leaving to start your own company and you're going to have to buy your own health insurance, you might be intimidated by that. And so you stay at Apple, even though you could actually extract more value for yourself working on your own. So of course, big business loves this system, but you talk to smaller businesses, you talk to startups, you talk to mid-sized businesses, they hate the current system. I hear from employers all the time who say, I'm tired of having to be the health benefits manager for my workers. I want to give them cash and let them buy their own health insurance. It's just the tax code basically makes that hard. Now, here's another thing that the Trump administration has done that hasn't gotten a lot of attention. They've created a regulation through the Treasury Department that allows employers now to fund health reimbursement arrangements that are kind of like HSAs, where you could then use that $3,000 or $5,000 or $10,000 to buy your own insurance. So that's a step in the right direction. And again, our plan actually builds on that and would require all startups to use that approach if they want to draw down the tax exclusion, which would do a lot to evolve us more in that direction where the worker controls the dollars rather than an HR bureaucrat at your employer.
All right. I think that is our time. But Avik, thank you so much for joining us. It's always great to talk to you.
Sam, same to you.
And thank you all for joining us this afternoon for another virtual conversation that I hope has made everyone smarter, faster. And thank you to our sponsor, United Health Group, for making this event possible. For all the news that matters on healthcare and everything else, check out Axios.com and the Axios app. I'd like to put in a special plug, if I could, for Vitals, our daily healthcare newsletter. You can sign up for that and all of our newsletters at signup.axios.com. And before you go, I do want to share one piece of exciting news about what's next for Axios. In the coming months, we will be expanding into local markets to get you smarter, faster about where you live, assuming you don't live in Washington. For more information on those local news endeavors, check out axios.com/local. Thanks again for joining, and we'll see you at axios.com.